Hello, and a very warm welcome to COVID-19 Updates from Singapore. My name is Caitlin Wee, and I'm a third-year medical student at NUS Yong Lu Lin School of Medicine. This is a series of webinars presented by NUS Yong Lu Lin School of Medicine, National University Health System, and Global Outbreak Alert and Response Network. The COVID-19 Updates from Singapore weekly webinar series will provide viewpoints and insights from a panel of leading experts in infectious diseases and related specialties and disciplines. It is now my honor to introduce you to our moderator, who is also the program director of this series. Recruited to establish an infectious disease training program in Singapore, he was the first infectious diseases head of department in the Communicable Disease Centre here in 1992. He is currently Associate Vice President for Health Innovation and Transformation, National University of Singapore. Ladies and gentlemen, Associate Professor David Allen.
Thank you, Caitlin. Good evening, friends, and thank you for joining us tonight. This is the 18th installment of our webinar, COVID-19 Updates from Singapore. We hope this broadcast finds you and your loved ones safe and happy. The topic for tonight's discussion is the ethics of immunity passports in COVID-19. Our guest expert to help us explore it is Dr. Voo Teck Chuan, whom I'll formally introduce after Dale's epidemiology update. Just a review of our customary episode format this week. We'll have a regional and international epidemiology update by Prof. Dale Fisher, followed by an in-depth talk by our visiting guest expert, Dr. Voo Teck Chuan. Question and answer period will follow. Then an update of COVID-19 related items which have come to Dale's attention this week. Finally, we'll end with a preview of next week's guest expert and the reveal of the mystery pandemic song or songs of the week. Please remember to send in your questions via the question function found on your Zoom toolbox along the bottom of your screen and the country from which you are watching. We welcome your comments. It's my pleasure to introduce Professor Dale Fisher, Professor of Medicine, National University Singapore, Yong Lu Lin School of Medicine, Senior Consultant, Division of Infectious Disease, National University Hospital, and Chair of the Global Outbreak Alert and Response Network, hosted by World Health Organization. Dale, over to you.
Cheers, David. I will share my screen. So I thought this week I'd probably do a few less countries, maybe talk about some specific points a little bit more. No real change here. 1 point in the last week, 30th of July to the 6th of August. So we've got 1.8 million in that time. It's the same as last week, and around 40,000 deaths. US, Brazil, India, clearly the front runners. This is the world epi curve, the yellow, as always, is PAHO, the Pan American Health Organization. These are the regions of WHO. What's clear is that obviously China got dwarfed many months ago, but you can see now there is increasing activity in our region with these pink bars here, and I'll explain more about that in a minute. Interestingly, the WHO has just released some information. They ask countries to do case report forms on all their cases. They've got information on about, I think about 6 million. What they've found is that in the 5 months from February to July, that the number of people infected aged younger ages, sort of 15 to 24, and also the next decade up, they've been responsible for a marked increase in. They've basically tripled. They were about 4.5% of all the cases. They're now about 15% of the cases. And we know about all the things happening at beaches and not social distancing and people nightclub outbreaks and things like that. So that was an interesting feature, and obviously gives us an opportunity to target the interventions. The UN has actually reported that also the childhood vaccinations are really struggling globally, as well as the fight against HIV, malaria and TB, various other screening campaigns, and it's all due to logistics and lack of access to healthcare and diverted priorities, I guess. In the US, the cancer diagnoses through March and April were about 50% of what the normal norm is. So obviously there's misdiagnoses, there's less emergency presentations for heart attacks, strokes. So this brings us back to the all-cause mortality that we spoke about a couple of weeks ago, that we might be looking at COVID deaths here, but the general ramifications are going to be much more broad-reaching. I think good signs in Africa, both in death rates and in numbers coming down. That's probably because Chikwe was on last week, but PAHO continues to go up. I have trouble believing this flat death curve while the number of cases is going up, but nonetheless it's there. MRO coming down with a fairly high death rate. Southeast Asia, driven by India, is there. Here's Western Pacific, which I'll talk more about in a minute, and Europe continues to have their Western and Eastern style epicurves, although a few more clusters on the Western side as people enjoy their summers. So this is how WIPRO is broken up. So you see this green represents the Philippines. So that's really the major hotspot, if you like, of Southeast Asia. Japan is there. Australia's the grey one. The blue one, Singapore, has generally come down. This little hump here is about 80% of these are Hong Kong. Hong Kong is basically in high double figures, low triple figures most days. So they're struggling. They're concerned. There's talk of, I don't know any of the details, but there's talk of them building 2 temporary hospitals to create about 2,500 beds. So their figures overall are about 4,000 cases and 38 deaths. So let's hope to see Hong Kong come out of this well. Here's some more from the Western Pacific side. So again, you can see Philippines is really the number that's driving it. Vietnam, small numbers, but nonetheless, things have really changed there, and I'll talk about these countries in a minute, as well as Papua New Guinea. So this is what Australia looks like. So it's your, I guess, classical first and second wave, but people do keep needing to remember that the waves are not about the virus; they're about the interventions to stop it. And obviously, when you stop your interventions and try and open up, then this is the risk. I'd like to give a shout out to Alan Cheng, who I've seen on TV the last couple of days, as the Chief Health Officer of Victoria. So he's a smart guy. I worked with him a lot in Australia, particularly up in Darwin, and shared a few publications with him. So good luck, Alan. Australia did an interesting study, or not study really, observation, where they, as you know, I've always had a problem with countries that don't isolate their positive cases. What they do is send them home and say, please don't go out. Actually, in Australia, they did let them go out. They were still allowed to go out and do some exercise, but that was pretty much it. And what they found is when they went round checking by door knocking to see if these people, and remember there's thousands now, thousands of active cases, they found that about 1/3 weren't actually at home. So you've literally got thousands of people with COVID-19 not home. So they've brought in the military that are going to be going around knocking on doors, again, ideally in a friendly way, but they've got capacity to place a $20,000 fine now. So it's like Australia's finally had enough. So very harsh lockdown invoked on last night. So there was a bit of panic buying, but pretty much shut down with a severe lockdown now. Okay, Japan. You can see they're up pretty consistently, over 1,000 cases a day, almost 1,500 one day. As I've said before, it started in central Tokyo in those host nightclubs, but that's now spread out to the more urban areas. And what that means is that instead of just younger people getting infected, now that it's in the community, it's older people as well. So that age demographic is changing. So you're going to see this black line start to come up, I fear, because this is just too many cases. They've still only done the state of emergency in Okinawa, so most of those cases are linked to US military. So US military being posted to Japan, they're supposed to be in their camps for the first 14 days, but clearly that's being breached and starting outbreaks, and we mentioned that a few weeks ago as well. So Okinawa's in the middle of its 2-week lockdown, and the rest of Japan really seems keen on trying to work through this rather than just suddenly shutting down and going for that response, which again I'll talk about later. The test positivity rate's about 5% here, so clearly they are struggling, and with 1,000 people a day, you need to be doing a lot of testing and contact tracing. So surge is underway. A couple of nice pictures. Da Nang, obviously a pretty well-known spot, and this was chosen by many people as part of a Vietnamese push to support domestic tourism. There was a big push, but this was actually the site of a fair bit of transmission. I can't see anywhere where it's suggested how it started, except that it's probably been going for a month, because there's quite a lot of seropositivity there already. So, and we know that really at least 2 weeks for the majority of antibody tests to become positive. Some as early as 8 days, but mostly more than 2 weeks. So that tells you the outbreak's probably been going for a month before it all appeared. So there's 4 factories involved. So the classic overcrowded workplace. One of the factories has had about 174 cases, I think. Anyway, this is now over 700, and there's 9 deaths altogether. They've tested about 52,000 people, and about 23% of them were asymptomatic. So this is just telling us you need to do fairly aggressive testing, and there's an intention to test the whole of Da Nang's popular hospitals springing up, because this is another country that doesn't allow its positive cases to go home. We know it's spread from Da Nang to at least 10 other locations, including Hanoi and Ho Chi Minh City. So it's going to be very interesting to see how Vietnam copes with this. They haven't really been challenged. They've certainly had cases and clusters over the 6 months, but this is clearly their biggest challenge. PNG, likewise, a very nice spot to spend some time. They're just realising their problems. Most of their tests are actually positive in healthcare workers and people that work at the National Department of Health and the National Disease Control Centre. And that tells me that they're the only ones that can access the tests. So there is a problem with testing. I think they've only done about 10,000 in the whole outbreak. So this will be interesting to see how it plays out in New Guinea. I know there's some Australians and New Zealanders have gone over there to try and help, but the reports are that their capacity to surge with testing or even hospital care is very, very limited. So this is very vulnerable, this area. So they've got a 2-week lockdown happening in Port Moresby, and they've got a curfew that starts at 10 o'clock every night. But community engagement's another problem there, that most people really don't know why or when to have a test, and there's pretty poor compliance with the distancing advice, really because the community hasn't been engaged enough as yet. Philippines, as I mentioned, you can see they're up at 5,000 cases a day now. I think since this graph, it hit 6,000 one day, or just short of that. This is really, it's the Southeast Asia's biggest hotspot. And you can see in the last month, they've really had many more cases than the rest of the whole outbreak put together. So the healthcare community declared that they were all about to get overwhelmed. I think 70 or 80% of all their ventilators are now being used, and they could really see that this is a problem. So the Philippine government has done lockdowns. This seems to be a core response, and one lockdown that will affect metropolitan Manila, Bulacan, Rizal, Laguna, and Cavite, which will affect around 27 million people. Their testing positivity rate still also 5%, so that's going to be a problem. And as we know, India has always had a lot of the cases, and that really is going unabated, although some of their serology shows very high. Some of the Mumbai slums are up at 57%, I saw was one. And so maybe this is a place where some areas will get herd immunity. This is one of the makeshift hospitals they've created that has capacity for about 10,000 people, this one. India's having some problems with rain, displacing tens of thousands of people, and particularly in east and northeastern India. So their testing positivity rate is 12.3% over the last few weeks. So clearly falling short, but they're still ambitious. I think they test about 600,000 people a day, and the plan is to be able to test about 1 million people a day. So that's one hell of a capacity. Okay, next one, Iran. A little bit blurry, but this country really since mid to end of April, when they eased its lockdowns, obviously when they were still having 1,000 cases a day, this is really taken off. There's a parliamentary report suggesting that this is maybe a 8 to 10-fold underestimate of the number of cases. They also only count deaths if they die in a COVID ward in a hospital. So anyone else that dies elsewhere isn't investigated. So clearly these are going to be the 200 deaths a day and nearly 3,000 cases a day is a problem. They've had about 300,000 altogether, about 16,000 deaths. They've had about 6,000 healthcare workers infected as well. Some quirky stories. So this is Denmark. You can see that they're having a little spike now, and this is possibly because they don't have all the fans at the football, but they celebrate together afterwards. So they think there might have been a super spreader event. But I thought it was quite interesting to see that you can actually, I guess you buy a space and you can watch the game live streaming, and you're actually there as well as a virtual image. there's also a slaughterhouse was done, as well as this super spreading event in Aarhus. Poland, you can see also that since they undid some of their lockdowns back in July, that it's been making its way back up. They've got my first what are they called? Anyway, there's about 25 nuns infected at this convent. That's the word I'm looking for, and so there's some nun infections which I haven't heard of. But again, it's a whole lot of people living closely together, so I guess it's the same thing. And also there's 29 people at a wedding, and the coal miner outbreaks have re-emerged as well. So we mentioned those many months ago. Coming to Singapore, here's our outbreaks. There's obviously a big testing flurry to try and clear the dorms now. I don't see this as a particular outbreak. I'm sure it's related to testing. And we're seeing more cases from overseas, obviously, because there are more cases overseas. So these are all diagnosed in quarantine. And our cases, as we know, it's been many days since we've had more than 5 community cases in a day. We've got a patient back in ICU over at NCID, and still plenty of work for the community care facilities, but because of those, they're really shielding the hospitals from having too many patients. Just 125 inpatients, and no deaths again for 3 or 4 weeks now. Okay, David, thank you.
Great, Dale. Thanks so much. And we apologize for technical difficulties. We'll work on that. But Dale, let me just ask you one quick question. You had mentioned the issue with home isolation in Australia and some of the problems that came up. Is there any capacity to actually isolate them in facility, or that's just not, that surge capacity doesn't exist?
Not in hospitals. They've just cancelled all their elective surgery, so that would help a little bit, but that's only going to be for their severe cases. If you're diagnosing 500 people a day and you multiply that by 14, it's what is that, 7,000?
Yeah.
It's where do you put them all? It's the same as all of us. We've all had to adapt, David. So yep. Whether it's Expo or whether it's what, and you saw what they did in India and what they're doing in Hong Kong and what Wuhan did. It's one thing that continues to disappoint me is so many countries don't take this message, and we know that trust is not something ideally to rely on.
Yeah. Okay. Well, thanks again, Dale. We'll talk to you a little later in the program. I need to remind you to send in your questions in the country where you're watching via the question function at the bottom of your Zoom screen. We do eagerly await your questions. We only have a very few so far. But it gives me great pleasure to introduce our guest expert tonight, Dr. Voo Teck Chuan. He's assistant professor at the Center for Biomedical Ethics, Yong Loo Lin School of Medicine, National University of Singapore. He's had a significant experience in bioethics policy writing, including on the topic of healthcare resource allocation due to COVID-19. And he's a member of the World Health Organization Working Group on Ethics in COVID-19. The title of his talk tonight is The Ethics of Immunity Passports in COVID-19. Over to you.
Right, thanks David, and hello everyone on the webinar. So my talk will cover the concept of immunity passports, what the key scientific and ethical considerations are, and approach for how immunity passports could be ethically deployed or implemented. So this topic of an immunity passport, I think relates to a question that is probably close to all our hearts. When can we go back to the lives we had before the pandemic? The hope, I think, is that a safe and effective vaccine will be developed to help us achieve this, but we don't know when this might happen. And if the vaccine were developed, we don't know how beneficial it would be and how soon it would reach us given potential distribution challenges. In the meantime, we've seen the devastating effects of lockdown measures on economies and social lives worldwide, and healthcare systems have also been negatively affected to deal with COVID-19. The option of living under lockdown or severe restrictive measures until a vaccine is developed is probably not palatable to most people. And so in countries where the rate of new infections is controlled, such as Singapore, measures to ease lockdowns have been implemented by lifting the restrictions gradually and in phases, and increasing the country's capacity for public health surveillance, testing, isolation, and contact tracing. So of course, even with these strategies and interventions, there are still a lot of limitations on where we can go, who we can meet, and it's probable that physical distancing, closure of schools and businesses, etc., might need to be put in place, as we have seen in many places, if infection cases start to rise significantly. So while we await a vaccine as a pathway to safely recover our lives, an idea that has been debated is whether we could use antibody or serological testing. To test people with past infections for antibodies to protect them against SARS-CoV-2 reinfection, and if they do have these antibodies, to issue them with what has been called an immunity passport, which can be defined as a health record or document that would certify individuals as immune or at low risk of infection so that they can be exempted from restrictive measures. A number of governments have been considering such an option since March or April to help recover their economy. And it's been reported that Estonia has already implemented such an app which functions as a digital immunity passport. So the idea of a passport may conjure out images of a physical passport, but it's more likely to look like this. In the Estonian context, users can supposedly download the antibody results on the app and show others, such as their employers, their reduced risk of spreading the coronavirus. So governments are pursuing such projects, and it seems that many companies and private organizations are also very interested in immunity passports to help them with reopening their businesses. So immunity passports are likely to come into operation in some countries at some point in time in the course of the pandemic. And policy and regulation will likely be needed at both the international and national levels. The questions I want to discuss today is whether immunity passports are ethically justifiable, and if so, how may they be ethically deployed to protect those with immunity passports, without immunity passports. So let me just go through the key ethical scientific considerations first before we attend to the ethical questions. So we know that people with COVID-19 will develop antibody response that will likely confer some level of protection, but we don't know the extent of this antibody-mediated protection, whether it protects against reinfection or whether it will only protect against severe disease. I think we also do not know how ill people must be before they develop sufficient antibodies to neutralize or block future infections. And we don't know whether we need to only detect neutralizing antibodies or whether we also need to look at other indicators that correlate with protection, which have yet to be established to certify someone as having protective immunity. We also don't know how long protective immunity might last, what the minimum duration is at least. So at present, we can't really be sure that a positive antibody test result means that a person has acquired protective immunity, and for how long towards the coronavirus. So it is because of all these indeterminate scientific questions that the World Health Organization issued a brief in April advising against the use of immunity passports as they may increase the risk of continued transmission. And the WHO will update its position based on new evidence. But how certain do we need to be? As you can see in this quote from a New England Journal of Medicine article, the authors contest the WHO's approach towards evidence on protective immunity and how assured we need to be about test reliability and accuracy. The WHO seems to be saying that we need guarantees, while these authors argue that while a high level of certainty would be good, the decision to implement immunity passports should ultimately be based on a threshold evidence and a threshold of error in serological testing that we can accept or tolerate, and weighing the costs and benefits of implementing immunity passports based on these thresholds. So for example, even if a highly accurate serological test that could indeed test for antibody-mediated protection is available, there will be a certain proportion of people tested who will be told that they have immunity when in fact they do not have. So this is what is called a false positive result, with the implication that individuals may be exempted from some restrictive measures when they should not be, as they share the same risk as those not certified. What is a predictable proportion of false positive results that we can accept? Can we accept a lower threshold of the extent of protection and monitor this over time? These are value judgments about risk, costs, and benefits and harms. And so it could be claimed that scientific acceptability cannot stand apart from values, and some would say ethics. I think the point here is that scientific evidence alone will not settle the question of whether to implement immunity passports. So even if we can establish the scientific thresholds and these thresholds are met, there are various ethical issues to consider in deciding whether or not to implement an immunity passport program. The first thing we might want to consider is what good reasons are there to support the use of immunity passport in the first place, especially if only a certain percentage of a country's population is only likely to be infected based on seroprevalence studies, right? So one key ethical reason is based on what public health ethicists call the least restrictive or least infringing principle, which states that among available options to achieve a public health goal, policymakers should choose that which least infringes on individual liberties and other interests. If immunity certification could indeed assure that individuals are not at risk of infection or contagiousness for a given period of time, then based on this principle, there would be no good reason to continue to subject them to restrictive measures for that period. Another reason is the potential benefits for individuals and society, which can be grouped into three categories: liberty restoration, pandemic response, and psychological assurance. As mentioned, immunity passports could help restore important liberties, which may be self-regarding, but also other-regarding. An immunity passport could, for example, enable people to safely visit and interact with others who are alone and help reduce the effects of social isolation, for example. They could also be used to assure essential workers, such as healthcare workers, that they are not susceptible to infection and will not infect others, and particularly their loved ones. And with that, they could be more psychologically at ease to be deployed in riskier activities such as collecting swab samples. So these two reasons, not infringing on individual liberties when it's not necessary to protect public health, and the benefits accrued, provide ethical support for immunity passports implementation. This is quite a high level sort of justification, and there are real concerns about potential real world adverse effects that might happen if an immunity passport program is implemented without due consideration of the ethical issues and potential important safeguards. And I will focus on three sets of concerns. The first set of concerns is the potential behaviors and risk that an immunity passport program might incentivize. Because immunity certification depends on previous infection, it might incentivize people to deliberately expose themselves to others with infection so as to obtain the passport, which places them and others at risk of serious harm. This is not a theoretical risk, but a plausible one. Some of us might have heard about COVID-19 parties being organized in some places in the US, where people gather with those diagnosed with COVID-19 in an attempt to get infected and get immunity. And one person in the US has been reported to have died from such a party after developing COVID-19. And besides deliberate self-infection, there's also the risk of fake certificates where, because of the benefits of having an immunity passport, non-immune people might pay for fake test results or assume the identity of someone else who has immunity. In general, the wider the benefits of having an immunity passport, if it can exempt you from most, if not most, restrictive measures, the more likely this behavioral risk would transpire. Possibly, education and information could mitigate this behavioral risk, but I think the best deterrent to deliberate exposure and fake certificates is to ensure that those without a certificate are not disproportionately disadvantaged in terms of their life opportunities. Another approach is to avail testing and certification only to some populations, such as those in essential services. And I'll come back to these points. The second set of ethical concerns relate to risks that are associated with being able to identify those who have immunity and those who do not or might not. I think it does seem like a frightening prospect if we live in a world where people with and without immunity can be easily identified in public places or buildings. Not only would it violate personal privacy, it might bring about invidious discrimination based on race, ethnicity, and so forth, and probably potential violence to members of particular groups. It could also bring about stigma, which devalues the identity of a person or disqualifies her from full social acceptance. And what is interesting about the potential of stigma in this context is that stigma is that it would attach to people who haven't been infected, which it differs from the norm because usually it is those with prior infections who face the risk of being stigmatized. So the upshot of this is that it is important to maintain immunity certification results as private and confidential health information, but there would be significant limits if immunity passports become applicable to many activities. So relevant authorities would need to identify those with immunity passports and those without, if, for example, they are used or they could allow certified individuals to go on international travels. So confidentiality would need to be quite limited for immunity passports to work. But what would still be important to do is to prevent directly observable and non-consensual identification. And one way to do this is to apply digital technologies to develop and implement passports, much like the app developed in Estonia, in which identification and access to information is authorized by the individual. Of course, laws and policies could be implemented to protect data privacy and as well as to deter discrimination based on immunity-associated race status. The last set of ethical concerns is the two-tier society which would emerge with an immunity passport program. So the term solidarity has been widely applied in many societies to meet the challenges of this pandemic. And one understanding of solidarity is that we should go through this crisis together. But an immunity passport program might fracture this solidarity and sense of togetherness together because it is designed to stratify people into different tiers of risk and different tiers of restrictions on their liberties. By exempting immune certified individuals from restrictive measures, these certified individuals will enjoy a set of liberties and privileges that a non-certified will not be able to access. So there is a need to consider and mitigate the potential disparity between the haves and have-nots in terms of restrictions on their lives and in terms of social economic welfare. One possible way for the state to do this is to focus serological testing and immunity certification on essential workers, as my colleagues and I have argued in a paper in the Journal of Infectious Disease. And such allocation would firstly be a practical necessity because serological tests would be limited, testing takes time and so forth. An ethical way, in light of this practical necessity, is to allocate and prioritize and make sure that immunity certification be used to maximize benefits for society as a whole. So by prioritizing essential workers from industries such as healthcare or food production for antibody testing and immune certification, the immunity passport could be deployed for the benefit of society as a whole. Another approach is to reduce the disparity between the have and have-nots is for the state to provide or focus social support such as income replacement on those who continue to remain under restrictive measures, especially if the burdens are severe. And most importantly, there shouldn't be a need to require immunity passports for most activities, whether it's employment, accessing healthcare to vote, or daily activities like going to a shopping mall, where non-immune certified individuals can continue to rely on physical distancing, face masks, which we're doing in Singapore, hand hygiene, etc., to minimize the risk of infection to others and themselves. So for example, those with immunity passports can apply these passports to access the shopping mall or park, while those without can register the entry to the mall for contact tracing and maintain physical distancing and so forth. Now, in this regard, I want to really emphasize that an immunity passport policy should only be implemented as a complementary or additional strategy to the other interventions that a state should apply to relax restrictive measures for society as a whole. And the reason I emphasize this is because at least some of the opposition towards immunity passports, if you look at the literature, is premised on the notion that a state or government will rely primarily on immunity certification in lieu of a vaccine to exit from lockdown measures. But an immunity passport policy is most practically and ethically applied as a component of a plan comprising of other measures such as gradual lifting, test, trace, isolate, and so forth. And the aim of adding such a policy like immunity passport would be to decrease the number of people subject to highly restrictive measures and increase more people able to take on high-risk means of providing essential services or caring for others. And this would be beneficial even if lockdowns need to be reimposed after being lifted. So with such an approach, and if measures such as social support are also implemented for non-immune people whose movements still need to be heavily restricted, the differential treatment between the non-certified and the non-immune will become less stark and more ethically acceptable. So in sum, to conclude, an immunity passport policy should be deployed only if the key scientific and ethical considerations I mentioned are met. Besides needing to meet, acceptable scientific thresholds, the ethics of an immunity passport policy depends on the policy goals or purposes. And I've argued here that they should primarily be used to maximize collective benefits for society. And one approach to achieve this is to focus testing and certification on those in high-risk occupations that provide essential services to others. And finally, I think we need to implement measures to mitigate potential harms, to prevent violation of individual liberties and rights, and prevent any resultant disadvantages to those without an immediate passport from becoming disproportionate and permanent. Over to you, David.
Thank you, Teck Chuan. That was great. We appreciate your thought-provoking discussion there. We do have some questions, and let me just sort of start off with a little bit of a housekeeping question is, what's the makeup of the World Health Organization working group on this, the ethics in COVID-19? Do you feel like it's a fair representation? I think ethical values would be universal, one would think, but what's your perspective?
Yeah, so I'm part of a WHO ethics working group, and we have convened a working group on immunity passports to write a paper, and it's quite geographically diverse in terms of comprising members of people from low and middle income countries as well as high income countries. In terms of discipline, it's also quite wide. There are obviously ethicists, but there are also public health practitioners and people. Two of our leaders from the Global Health Ethics Unit at the WHO. So this is the team that have been trying to work out some sort of, I would say, a white paper to guide governments and companies to implement immunity passports ethically.
Great. What's to prevent a country, a rogue state whose economy depends on its people working overseas, from falsifying immunity passports for its people? I mean, they have a motivation to do so. Otherwise, their economy just grinds to a halt. Yeah.
So this is, I think, a real risk. I think it was reported about a few months back that travel certificates based on active infection testing was implemented in Indonesia, and all of a sudden there was a big market for these fake certificates, so that people can travel and go to other places in Indonesia. I think it's based on a religious event. So there is a risk. And I think even in low and middle income countries contexts, it is possible to implement, to use digital technologies to make sure that the test results are linked with the identity so that people can't falsify the results. So probably to prevent such fake certificates, you do need to rely on blockchain technologies, for example.
Okay, great. Excuse me, there's a question here from Emily Yo in Singapore who'd like to know, what does Singapore stand on using the concept of an immunity passport? Is there a more ideal point in time or situation other than now where an immunity passport will be implemented? Are you able to share that with us tonight?
Well, I wish I could, but I think I might be the only person in Singapore very interested in this idea. We have also colleagues from School of Public Health working on this. But I would think that our common approach would be to take a very pragmatic approach. If only a very small percentage of our population would likely to have some sort of immunity, then I would imagine that Singapore would not pursue this. And already we have done very well in terms of lifting the circuit breaker measures, as we call it in Singapore. So we are doing quite well. So depending on how things pan out, but at present, I'm not sure whether there's any need to pursue immunity passports, especially if the science is not right.
Joe Augustin says, can it be argued that personal liberties be curtailed for the greater good? Ethics in favor of the masses versus the individual?
Yeah, so in public health, obviously you have to sort of maintain individual liberties, right? You can't really sacrifice them entirely to protect the whole, because the whole consists of individuals. But we tend to think of justified infringement of individual liberties and rights. So if I have an infection, the state should have a right to put me under isolation, for example, in order to protect others. So this principle of prevention of harm to others is quite well accepted in public health ethics. And I think most reasonable people would accept it as a justified infringement of individual liberties. Of course, other principles we need to come in. You need to sort of support these people as they are confined. Food support at least, if not financial support. So they ensure those conditions in which they are quarantined or isolated are reasonable and protects their welfare.
BX Ong asks, what's the main ethical consideration for our Olympians to access immunity passports if Tokyo 2020 is to proceed, or 2021, excuse me?
I don't know. I think one of the major potential idea for immunity passport is to apply them to international travel. Again, the science is not right, and we need to sort of establish the acceptable thresholds of error. And I'm not sure whether or not it could apply to a particular population at Olympic athletes. I don't know how many of them would have acquired protected.
Right. Yeah. Interesting question from Ing Suithio, who's asked, if immunity passports are approved for healthcare workers, would it be reasonable for patients to request to be seen by healthcare workers and medical students who hold such passports?
Yeah, that's a great question, right? So I think you have to sort of protect the this health information about healthcare workers from the patients. And I don't know if you want to demand someone with immunity certification, the appropriate response would be that, well, firstly, there aren't enough healthcare workers. We need all hands on deck in a time of a pandemic, and the safety to the patient could be assured by PPE, hand hygiene, and so forth. So there's no reason to be, so afraid of being in contact with a non-immune person that you would resist care. So I would suggest that as a possible reasonable response.
If social distancing works and PPE, et cetera, when implemented properly, why do we need immunity passports when they're fraught with all the ethical dilemmas of inequality or inequity, stigma, and unintended harms? Which has the greater risk to societal harm?
So as I've mentioned in my talk, I think what everyone's or companies or organizations or governments would like to do is to sort of have a more assured way of getting people back to work, right? So and one possibility to do this is to have immunity passports. At any point in time, all these things that we're enjoying under current circuit breaker relaxation, there are still many things that we cannot do. So in a couple of months' time, I think, or maybe next month, some of us might be able to go to Malaysia, but it's for essential work, right? So with immunity passports, you could provide more green lanes, so to speak, for people to use these passports, and potentially some of us could even go for holidays. But that's where the risk to solidarity will be quite tangible, because you see some people go international travel for holidays, and I can't go because I don't get immunity. That's where all the risks come in. So I think the question does make a lot of sense. you have to put in the right measures and make sure that everyone could still live a reasonable standard of living as you apply immunity passports. And as I mentioned in my talk, you should sort of focus, if you were to really apply them, to focus on essential workers, so to give them a kind of psychological assurance. So I think this would be a most ethically defensible use of resources to implement immunity passports.
Steve Allen from Ohio has asked, how do you think we should determine and incorporate a time limitation on immunity passports, since we have no idea how long protection will last? And if we do have a valid, scientifically valid immunity passport?
Yeah, I think so. I think the first thing we need to do is to understand at least how it works, right? Whether it's, what is the minimum duration, for example, right? And once you can sort of ascertain that to a reasonable degree of certainty, then appropriate way would be to sort of monitor these individuals over time, and to maybe get them back to testing at reasonable intervals, and sort of see where their antibody levels are. So you do need to apply some sort of monitoring system, surveillance system, as you apply such a program. I think this is, you can't ascertain long-term immunity if you don't have time, right? So you do need to monitor.
So this is a rather complex question, but an important question. Samantha Sea from Germany has asked, it seems there's inherent contradictions in the policies or the strategy. We want immunity passports to minimize restrictions and infringements on their liberties, and yet we need to minimize the difference of treatment of people with and without passports to reduce perverse incentivization. Could you clarify on this and comment on how you'd envision it being resolved?
I think we have to work at two levels, right? On the one level, there is some sort of high level in principle justification, right? So if you think about why you want to continue to impose restrictions on someone who really has immunity, it doesn't really make that much kind of sense, right? But you also have to think about the kind of consequences that might happen in the real world if you don't sort of focus the program on to achieve public health and public health goods and public goods, right? So you imagine a world in which someone with immunities, people without immunity can start to not wear masks in the public, and then you have a group of people walking around with masks and a group of people not walking around masks, and you can't really tell who has immunity or not. And so that's where I think physical risk, privacy risk, stigma risk, all would likely occur. And so my suggestion is that while it's true that liberty, the least infringement principle could justify an immunity passport program, in practice it's best that we focus on what will help to maximize society benefits for society.
Great. Teck Chuan, I want to thank you. This has been really good. We appreciate you taking time. We're going to move to Dale to do his update for the week, and then off after that. Thanks. Over to you, Dale.
Thanks, David. Thanks, Teck Chuan. It's always good to have some thought-provoking discussion. I hope I've got a few more for you tonight, because this is what people are talking about now, David. The origins of the virus, returning to business as usual in the hospitals in Singapore, the whole global response and what we're seeing is, which we're labeling consequence management, and then I want to get a bit of a shout out to ProMed. So, firstly, let me just talk about this. So, two of my colleagues from WHO just recently returned from this mission. Now, the outcomes of the mission aren't released yet, so this is what I'm telling you is speculation, but this is going to be very troublesome. It's two of them were there. They were there for 3 weeks. There's now to get a strategy together to how we look into the origins of the virus. Now, I heard Mike Ryan on the other day say that actually there's no reason to presume this came from Wuhan. Apparently, Wuhan had some specific atypical pneumonia surveillance, so that would make them more sensitive to picking up things. And I recall seeing those descriptions of the first cases, and it was 5 out of the first 6 had no contact with Wuhan market. So that's obviously the one on market is the one we talk about, but we know markets get infected and amplify it, and we know it can be carried on refrigerated food, for instance. It's been cultured from there. There was the big outbreak in the Xinfadi market in Beijing, but we know it didn't start there. So this will be one of the first questions, I think, is what was the relationship with the Wuhan market? Now, this is going to be another big part of the speculation, this wastewater. This process of examining wastewater has been used to diagnose polio re-emergence and to monitor polio situations, other enteric pathogens, even illicit drugs, antibiotic resistance, looking to see if the virus, and it's particularly good for subclinical presentations, which obviously we can see a lot of in COVID-19. So it's been cultured in many countries, certainly Netherlands, Italy, US, Australia. They've all cultured COVID-19 from their wastewater. And if we can go back, we can get another piece of information which will tell us where it was and when it might have been, if there's stored samples, for instance, where it might have emerged earlier than when clinical. The next one is, now there's the story of the pangolins, of course, but they also came from Malaysia originally, right? So is that part of the puzzle? We know that 15% of the cats in Wuhan are seropositive, albeit after their outbreak, but cats really do pick up this virus, and we keep saying it's not a big part of the transmission chain, but could it have been part of the origins? We don't know. There's plenty of bats in the world, and what sort of surveillance of bats for like viruses around the world are to be examined. And then there's of course going to be a whole lot of phylogenetic work to try and piece it together. We know that in Shanghai in early January, there were actually 2 clades. It was the Wuhan clade, and there was another one that was quite distinct, suggesting that it wasn't all coming from Wuhan, it wasn't all straight away. So we don't actually really know anything. We've got a lot of questions, and here's my pessimism, is that I don't think anyone's going to want to try hard, because if it looks like it's your country, and if it looks like it's China, people have already made it clear that they want compensation if it's proven to come from there. So the incentive, the scientific incentive is there, but the police point the finger and say, you know, what about your projects? So I think this will be very murky, very difficult to get to the bottom of, but there'll obviously be more talk about it. Let's talk just briefly about returning to business as usual in hospitals. We all, there needs to be a point that at what trigger is the community prevalence enough that we need to do more on patients in hospitals. And what I mean by that is, do we want to swab everyone going for an operation? Obviously, if there's a really low community prevalence, then you wouldn't bother. Do we want to wear full PPE for every operation? Again, same answer. Do we want to wear full PPE if we're doing an aerosol generating procedure on someone that's asymptomatic? Do we want to swab every hospital admission? We currently swab every nursing home admission so that it doesn't get in. So these are some questions about what is that trigger point at which we might want to do it. What is the community prevalence? So as I always do when I have trouble working something out, is I throw it to the smartest modeler in the world, who we all know as Alex Cook, who was an earlier speaker, and he came back with this, which I thought was very impressive. We assumed, so these are very conservative assumptions. We assume a 14-day infectious period. That's too much, right? In most cases. We assumed that each case diagnosed in the community is matched to 4 undiagnosed cases. Again, that's quite a lot. I think in Singapore we're better than that. We're assuming all infections are asymptomatic, and we know that's not true. We've still got capacity to ask people if they have symptoms. And we're assuming that it's a random draw from the population and that the epidemic is at a steady state. Now, so if you say there's total cases in the last 7 days, so the average is 1, so we've got 7 cases a week, 10 to 20 cases a week, or up to 500 cases a week, okay? So with these assumptions, this is the risk he's calculated, the risk that you will see somebody who's asymptomatic with COVID-19. So even up at 50, 60 cases a day or 500 cases a week, the risk is still only about 1 in 1,000 with our population. So I think we can be a little bit more relaxed about it. Of course, it matters more if you're seeing a lot of patients, for instance, because once you've seen 1,000 patients, then you'll probably see someone with COVID, which is why we still do the distancing and wear the masks and things like that. But it's really somewhat reassuring, and the question will always come back to is, what is your appetite for risk? So, there may be a point with a high risk operation, or maybe dental procedures or something like that. You'll say, look, this is very aerosol generating. We really don't want to take the risk. We'll all wear PPE even though he's asymptomatic, or we'll do more tests on patients as they come in. So anyway, this is just a discussion that's been having at the moment on what is that trigger. This will be an MOH decision, obviously, but doesn't stop us talking about and hypothesizing. So the next one I wanted to talk about was this sort of consequence management, if you like, and this is this whole concept that we can't seem to get leaders of the world off the fact that the main outbreak responses are shutting down or locking down and shutting borders. Beyond the immediate mortality and morbidity, and possibly long-term medical issues, there's obviously major long-term ramifications with what we're doing to education and to the economy, and we have to be able to live with this virus. Furthermore, we know that antibodies are wane certainly over the months post-infection. We don't know what that means. We don't know if a re-challenge will see the antibodies come back, but we know they're falling. And imagine if you were locked down and shutting borders and really not trying to do the public health response. And then in a year, everyone that's been infected, you've got to start again because it's we find that it's a recurrent infection, or there's no vaccine comes along or something like that. So the message is we really have to live with the virus and stop locking down, or as someone proposed, that we lock down for a month every 2 months or something. So that's very negative. So how do we get this message out there? The vaccine, there's no sign of it abating. It's obviously more and more every week. And it's very unlikely that the vaccine is going to be the magic answer that so many people are waiting for. I actually doubt if most countries even have a decent incident management system to address all the pillars of outbreak response. And we've been through them before, all the contact tracing, all the isolating of cases, the quarantining, the testing, infection control, all these things. And these all need to be in place. And why countries just think, oh, we've got a lot of cases again, let's lock down. It shouldn't be let's lock down, it's let's get it right. So, or if you have to lock down while you're getting it right, then so be it. But don't just unlock because your numbers are low. General's comment the other day, he says, just do everything. I think it was do it all. It was a bit like a Nike thing. Do it all. Don't just wear a mask. Don't just socially distance. Don't just contact trace. Do everything. So I think that's a good message, and let's just stop dealing with the consequences of not working out how to live with the virus. So I say no to all this stuff. So ProMed, This is, I'm sure, familiar to most people that are watching. We look at this one, and it was midnight on the 30th of December. Undiagnosed pneumonia in China, Hubei, and Wuhan. Unexplained pneumonia has been isolated. Test results will be announced as soon as possible. I like this one. The so-called unexplained pneumonia cases refer to following 4 cases, that's lower down in the letter, that cannot be diagnosed, and they're all at the same time. There's fever, imaging characteristics of pneumonia, acute respiratory distress syndrome, reduced or normal white cell counts at the early stage of onset, the number of lymphocytes is reduced, and after treatment with antibiotics for 3 to 5 days, the condition did not improve significantly. So very familiar stuff, and I want to give a bit of a cry out to ProMed. This is a large part of their global group. This is Marjorie Pollack and Larry Madoff, and ProMed stands for the Program for Monitoring Emerging Diseases. So they've been going since 1994. This was a picture taken in Hyderabad in 2016, which they say is the last time they had a face-to-face. So this is their team plus a few guests at that. They've got 32, they work 24 hours a day, 7 days a week. They've got about 80,000 subscribers. They've got ProMed staff and moderators across the world in 32 different countries. And this is, I would argue, probably the world's best early warning system. They're monitoring a lot of communications and rumors, and they've got contacts, and they're following up things, and they share information. They've put out 500 ProMed pieces on COVID-19, so they're a big source of me every week. They were first to share the world on SARS, MERS, some of the Ebola outbreaks, Zika. So good on them. But a little story for you, David. I think you might know it. This is Larry Madoff. He was round at my place in 2017. He was here for a conference that was running in Singapore on emerging infectious diseases, and he had to give a talk, and it was called "Where's the Next One Coming From?" There was him and Nick White and a few others were part of a panel deciding what's going to be the next big one, and because the night before I'd been telling him that the next big one is going to be a novel coronavirus, he put this up on his slide, and a friend of mine, Bart Curry, took the photo and sent it to me. So here I was thinking, back in January, thinking how smart I was, and I told Lin Fo Wang, I predicted this, and he said, so did I. Except he predicted it was a bat coronavirus. So he really trumped me, and he even put it in the paper. I'm almost certain that in the next 10 years, a new killer virus will be spread by bats will emerge. So there's a couple of fun stories, but really it's all about ProMed. I take my hats off to you, the people that thought it up and the people that run it. David, I just before going, I just wanted to share with everyone that we've got about 5 or 6 weeks left. I know you're going to introduce next week's speaker in a second, but if everyone on this call, they really should be telling their friends to register, because we've had a whole lineup of all-stars in our program, but coming up after Peter Horby next week, there's Maria Van Kerkhoff and Mike Ryan, who are the two people that flank the Director General in his press conferences every day. There's Chao Bin, who's a Chinese hero who was in Wuhan throughout and did some of the big trials there. And there's Jeremy Farrar, who's, of course, head of the Wellcome Trust. So there's some really big names coming up, and please tell your friends. Okay, thanks, David.
All right, thanks, Dale. We'd like to thank Teck Chuan for taking time from his evening to be with us and enlighten us. We very much appreciate that. Next week's speaker will be Peter Horby, as Dale has mentioned. He's Professor of Emerging Infectious Diseases and Global Health at University of Oxford. He's Executive Director of International Severe Acute Respiratory and Emerging Infection Consortium. He's also the principal investigator of the recovery trial. The title of his talk will be COVID-19 Clinical Trials from Concept to Results. There's a chat box at the bottom of your screen. Please use it. It'll be open for another 10 minutes or so, and we want to hear back from you. It helps us a lot. Until next week, stay safe, wear your mask, wash your hands, and be wary of those reassuring you of a quick fix to this pandemic. This week, we're pleased to have 2 pandemic songs of the week. It's an auspicious webinar episode, number 18, and we want to thank our contributors. Annie Tan is Assistant Director of Continuing Education and Training, School of Medicine, National University of Singapore, without whom our webinar would not happen. She's given us Gotta Be Patient by Bare Naked Ladies, Michael Bublé, and Sophia Reyes. Additionally, Associate Professor Na Min In, who's a senior consultant in the Department of Pathology at National University Hospital, has given us We Can Work It Out by the Beatles. Enjoy them both, and good night.